going to begin to introduce our distinguished guest today, Dr. Beth Mynatt. She is the Executive Director of Georgia Tech's Institute for People and Technology. She is also a distinguished professor in the College of Computing and the Director of the Everyday Computing Lab. Dr. Mynatt is also the Chair of the Computing Community Consortium and serves as a member of the National Academy's Computer Science and Telecommunications Board. She has been recognized as an ACM Fellow, a member of the SIG High Academy, and is an internationally recognized expert in the areas of ubiquitous computing and assistive technologies. Her research contributes to ongoing work in personal health informatics, computer-supported collaborative work, and HCI design. So with that, let's welcome Dr. Mynatt today. Thank you.
Thank you. So it's a real honor to be here. Let me tell you a teeny bit about myself and tell you about the kind of talk I'm going to give. So I have been at Georgia Tech for ages now. I think I'm now in year 18, professor of interactive computing. I was the founding director of our PhD program in human-centered computing. So when I say HCC, it's actually a proper term for us. I'm very excited about that program. And the kind of talk I'm giving today is the kind of talk that your advisors will tell you not to give, because I'm going to do a breadth talk instead of a depth talk. But I'm going to talk to you about kind of my history in working with my laboratory and my students about how we kind of fell into doing healthcare research and the perspective that I came through from a ubiquitous computing perspective. So I will be touching on, I think, 6 PhD dissertations that have come out of my laboratory. And this is where I remind myself to say I'm also looking for new PhD students to join this work. So if any of this is interest to you, please contact me, because I know I have a bunch of master students here. So I've got some possible targets. And information about all of this would be on my website at the Everyday Computing Lab. So that said, before I was at Georgia Tech, I was at Xerox PARC, back when it was actually Xerox PARC and not just PARC, working with Mark Weiser, Roy Wanda, and others on ubiquitous computing. And for me, you have to go back 20 plus years now in that history. This was the time before we were all wandering around with tablets and smartphones and all these devices. And so to be immersed in an environment where the question was, what did it mean when you had pervasive access to computing technologies, on a day-to-day basis, on an informal basis, how would that change kind of the structure of human activity? And so I took that agenda with me to Georgia Tech when I joined the faculty in '98 and created the Everyday Computing Lab. And so we started with this question of how will everyday life be transformed by having this pervasive access to computing technologies. And I will say that I remember being in strong debates at Xerox PARC about how no one was going to wander around talking to like a cell phone with headphones, because it would look like they were just talking into thin air and nobody would walk around looking that crazy and deranged. We got that one wrong. But we also had a lot of conjectures around kind of the use and utility of different form factors. But the main point is that we had new assumptions about people's experiences with computing, 24/7 operation, informal interaction, and then it was going to create much more of a consumer space, and then that was going to have an impact in terms of our day-to-day experiences. And what happened for me is that as we started looking at the agenda around everyday computing, I fell into the opportunity of working at the Aware Home. So the Aware Home is a still relatively unique facility. We started designing it in '98. I think it came online around 2000. That was looking at, again, that kind of UB question, but what happens when a home can be aware of its occupants, of families, of activities, of everything that was going on. And we were the typical young computer science-y type folks kind of searching for good problems and meaningful problems, because as faculty members, we weren't terribly interesting. We were never at home. We were always at work. So what kinds of problems would be worthwhile? And this is how I started working in healthcare. And so for me, what came out of this was a perspective on healthcare that may be different from some of the students in this room, in the sense that I came at healthcare from that everyday experience. That healthcare was personal, that it was social, that it was negotiated, and it was very much not the experience of clinical care healthcare delivery from a traditional healthcare system. And part of what I will show you in the trajectory of my work is how I've come to terms with finding the integration or the middle ground between those perspectives. So as I started at this, again, my training was in computer science, my training was in engineering psychology, my training was in HCI, but now I'm starting to put together this agenda around healthcare and human-centered computing. And so the pieces that I have worked to stitch together over the years have included things like, what is the theoretical basis that I'm going to be coming from? Because again, I come from kind of classic psychology, human factors, engineering psychology. So there was a question of, okay, there are other theories out there that I needed to inform the design and evaluation of my work. And how would I start kind of working through that? So the theories on here are the ones that over the projects that I will discuss are ones that we've become more facile with in terms of relying both from a Gestalt sense of informing design, but then also kind of the objects or constructs within the system and then the evaluations of the system. So starting with locus of control, social cognitive theory, identity presentation. I always love Mike Goffman. He's always in my work. Health belief model, trans-theoretical model change, lots of discussions around that. So I'm not quite sure how familiar these theories are to this audience. I'm getting some head nods. But this is kind of the basis of where we were starting to work. But then what I did with that was I clicked a lot, okay, was then brought an HCI mentality to that. So what did it mean to have an HCI design process that really focused on ethnographic inquiry, that focused on iterative design, that participatory design, that focused on evaluating things out in the real world, not in the laboratory. And part of the challenge, and for anyone who's trying to get NIH funding in this room, is, how do you blend these approaches and how you pull these approaches together, because most clinical NIH-like research tends to treat the technology as fixed. And it's one of the things that are controlled within understanding possible outcomes. But deeply coming from an HCI tradition, that iteration and that participation was a big part of the work that we were doing. And one of the things that I will hopefully remember to mention as I go through the projects was this notion of kind of finding key informants. So we weren't doing full-scale ethnographic inquiry, but we were going out into the field and kind of understanding the problem space that we were working with. But a glimmer of we knew we were on the right track was we would find particular informants that had kind of an inside knowledge and perspective of the healthcare setting that we were looking at. And if we kind of listened in and paid attention to what those informants were telling us, then we would discover new approaches to things that we could do that involved computational technology. I was also sitting in the College of Computing, PhD in computer science. So one of our questions was also not what we were innovating really on the human computing side, but good old-fashioned computer science questions. What were kind of the innovations within that space? And I won't say that that has been kind of the depth of all the work that I've done, but we have stumbled onto some pretty hard questions that generally involve collaborations with folks coming out of machine learning or activity recognition. And as I'll describe on my very first project, I stumbled onto a question that I thought was easy to answer, which is, can you just say today is a normal day for an individual? And I've discovered just how hard answering that question is in any kind of reliable computational way. As I got further and further into healthcare research, then I had to start creating measurements or evaluations of my work that were based on health outcomes. And so the kinds of things that we have looked at have been questions of disease management, so chronic disease management. So if you're in diabetes work, you look at a A1C value to understand, for example, long-term sugar control within the body. We were looking for behavior change. A lot of these things weren't persuasive in a BJ Fogg kind of way, but they were trying to shift human behavior in what ways that we could measure that in any kind of reliable way. From an aging perspective, but also associated with chronic disease and other things, we wanted to facilitate independence, right? If we could, I'm the opposite of a traditional healthcare researcher. If I can keep people out of the healthcare system, then I probably have been successful. So facilitating that independence. And then much of what we do, I would say, is that we're trying to scale effective healthcare delivery. In the sense that I'm not a researcher that is attempting to understand something and then automate it, but I'm trying to find where those key folks are being incredibly effective, but they're limited in the scale of what they can do, especially within the resource restrictions sitting around healthcare. How can I scale and amplify their effectiveness? And hopefully you see that theme in my work. So if we put all of this together, the question is, okay, what type of interventions we're trying to create? What were the design objectives? So we have looked at things over the years, facilitating awareness. That's, this today and normal day kind of question. Facilitating caregiving, facilitating problem solving and sense making as people make sense of their own bodies and start making decisions around that. We have focused in on contracts such as self-efficacy and locus of control, and that really has been an entryway to some of the work that we've done overall around patient engagement and minimizing barriers to care. And then this notion of how we kind of scale healthcare delivery, we have looked at really the notion of healthcare facilitation. I'll touch on that briefly. And then only in the past year or so have I actually started to work on outcomes and interventions associated with mental health. So I'll finish with that. So that's the cheat sheet of kind of everything I'm going to talk about, and now I'm just going to go through a series of projects to give you an idea of what that has looked like in actual research and how things have shifted over time. This clicker and I are not getting along. All right. So first piece of work, someone said yesterday, is this the butterfly piece? Yeah, this is the butterfly piece. This is the work that we did, one of the first pieces of work in the Aware Home around aging in place. And we really started this with kind of greenfield assistant professor, we're not sure what we're doing, but the charter that had been given to us is what kind of technologies in the home could facilitate independence and quality of life for aging adults. And so we were fumbling around, muddling through that space, and we started talking to people who could help us understand the question of, well, why would someone move out of an independent setting into an institutional care setting? And so our informant in this turned out to be chaplains. So these were folks who tended to work in institutional care settings, and they would counsel families who were grappling with the question of, should my mom or my dad move from their longtime family home, into this setting? And part of what we came to understand in those discussions was at first the power of the decision making had shifted. It really was the question, should my mom or my dad do this? It was very much kind of around the adult caregiver who was really kind of at the center of these discussions. One of the things the chaplain told us was that from their perspective, that there was always a profound sense of loss that associated these. These were non-trivial transitions that were taking place. And what they were hearing from the adult children was I live 2 states away, I live 3 time zones away, I need to know that my mom or my dad is okay on a day-to-day basis. And so we ended up coming up with this construct of peace of mind awareness. And so while most of the research community was looking at responding to kind of adverse situations that might happen, very rarely, we were focused on the 99.9% of the time of what is going on with an individual and how would you communicate this in a privacy-preserving way. So this is where we started with the question of, is today a normal day? How do you convey a sense of activity about what's happening in someone's house so that an adult caregiver would have peace of mind? We did a lot of interesting things in this research. I will say that this is where I started forging connections with the computational perception machine learning folks. And they had all sorts of fun ideas like, okay, well, when grandma's having a bad day, her picture could fade to gray. I'm like, okay, this is kind of like a little Dorian Gray and maybe not quite what I want to go to from a social perspective. But more importantly, it was actually difficult for the machine to decide today's a bad day. Today just might be a rainy day. Today it might just be a slow day. Maybe the day before was really active, and so it completely makes sense. Or Mondays tend to be quiet because Sundays are big days. So this question of how we would represent that, and then as I said, do this in a privacy-preserving way. Because the other suggestion was essentially granny cam, like 24/7 surveillance. That was also not going over well with my participants. And so what we ended up with was this design. So I will see butterflies forever in my career. But where the butterfly indicated how active a person had been that particular day, and you can see it in the context of other days. And I won't say that the design is perfect, but what we were able to see when we studied this was that this was very much an interpretation within a social relationship. This wasn't a generic visualization for a person off the street. to interpret. This was a, I said an adult son, an adult daughter, an adult daughter-in-law that was on the other side of this equation. And they would bring all of their knowledge about that person, about their activities, and bring those things together. And so it was a successful design in the sense that it combined all of these elements. So I'm going to keep pushing forward, but the world started to change a bit, and one of the things that we saw was mobile computing, although as you can tell it was really old mobile computing. So for those of you who are too young, that's Nokia. So big smartphone provider at the time. But when we started looking at independence and quality of life for aging adults, we started to look at chronic diseases associated with aging. And so this is how I started working with Linda Mamikina, who's now at Columbia, faculty member in Columbia Medical School, on mobile tools for diabetes management. And so in this case, we had a new informant. Our informant was people who are diabetes educators who would counsel individuals who've been newly diagnosed with diabetes. And so she became a prime partner in the work that we're doing. And what she said to us that kind of stuck with us, so the construct that stuck with us, was they need to learn to become detectives, right? They need to learn about their own body and the impact of all of their aspects of life. And she was frustrated because they would come to class, they would come to class once a week or once every other week to meet with her. And they got pretty good at book knowledge of diabetes, right? At the end of N weeks of coming to class, they could pass a test and they understood kind of the basics of diabetes. But they had failed was how to internalize that into their own system. So we built what we conceptualized as a detective tool. And the detective tool worked by, you'll recognize this assessment methodology, but essentially we just told people anytime diabetes rears its head, you're going about your daily life, anytime it kind of rears its head, capture that moment, capture that frustration, and share it with the system that was, would share that information with the diabetes educator. So we got pictures of salads, we got pictures of pizza, we got pictures of, all sorts of, we got pictures of menus that were frustrating, we got pictures of grocery store labels, we got pictures of glucose meters, and the patients would share their, like, I'm having trouble with this. And what evolved in that relationship with the educator was instead of generically talking about diabetes, they were able to hone in and focus on a particular problem that they wanted to master. So a person would post, I'm really frustrated with my morning sugar levels. They're high, I don't understand why, all I've done is sleep. Why in the world are my levels so high? And so the educator would say, well, remember in class we talked about having a late night snack because the late night snack will kind of help even out the sugar during the night. And so then they would post the next day. I'm like, well, I did what you told me to do, but nothing got better. And so she would post back like, well, what was the snack? Well, it was a candy bar. Okay, maybe we should try a snack that's kind of, more in the range of, granola or something else that would kind of temper things out in yogurt. And then they would try it again, and then they would develop these very small cycles of mastery. And so what we were able to see in our qualitative data analysis by looking at all of this back and forth with the educator was that patients, diabetics, were able to pinpoint problems that mattered to them, like what to order at their favorite restaurant where they go every Tuesday night with their friends, or what, can they still drink orange juice in the morning? They'd create these little experiments, and the system, it was very rudimentary, but the system would help them work through that. And one of the now constructs that we were starting to measure was locus of control. And this is a healthcare construct that essentially measures how much a person believes that their own actions have an effect on their health. And what we saw in the data was that the individuals that were using the system started to improve or increase that internal locus of control. And then the individuals who didn't use the system, there were actually a lot of people kind of scared of the Nokia phone at the time. I don't want to break it, it's very expensive. But when we would dive into the detail on them, their locus of control was such that they either believed that they had no control over it because it was genetic, everybody in my family has diabetes, I got diabetes, or they just believed that they should, that it was all based on what their doctor would tell them. And so they would just try to routinely follow just that prescriptive advice. And what we know from long-term adherence is that people can do that for a very short period of time, like this is what the doctor told me to eat, but then at some point in time they will essentially start to fall off the wagon with respect to that advice. And the long-term perspective is that folks could begin to contextualize diabetes management in their day-to-day lives so they could be successful. We were very excited. Sometimes technology transfer is done by students moving from one location to another. Lena graduated from Georgia Tech, went to Columbia, and we're now wrapping up an R01 that's been led by Columbia that then took this research and then developed a more sophisticated system that has integrated more aspects of diabetes curriculum into a web-based but problem-solving tool. But again, the idea is that it's still the same. How do you teach people to be detectives around their everyday life? Parts of the system I don't like because NIH insisted that we automate the process. So we actually took the diabetes educator out of the system. So in my mind, it's kind of an evaluation of how far you can go with that approach. But what I would really like would be a combination that pulls these things together. So moving on. So we're up to PhD student number 3. So this is Andrew Miller's work. This is how I started working with adolescents. And so we had a problem kind of fall into our lap. We were working with Humana, which is a healthcare provider, healthcare system at Georgia Tech. And they had this intervention that they created, but they wanted a third-party evaluation. It's like, okay, that's an interesting way to get started. Andrew was a master's student at the time. And so their intervention was to give schools pedometers that the schools would then distribute to the kids, and it was about increasing physical activity. So you had a pedometer, very kind of early quantified stuff. Have a pedometer, you have some feedback about the steps you're taking, it's a competition, and the school who has the most steps after a certain period of time wins like cool equipment for their gym or something like that. So we were to go into all those schools and kind of see how this played out. So we discovered a lot of things in this research. First off, it was incredibly school dependent. So there were schools that would essentially make the time and space for this. You know, they would open the gym early so kids could come in and do the steps. So they integrated it into their classroom. Not surprisingly, those were the kids who did well. There were the schools for whom this was kind of barely existent in terms of their social experience with their teachers or with the rest of their peers. Not surprisingly, those students didn't do as well. There were the schools that focused on the competition and handed all the pedometers to the cross-country team. Kind of missed the point. One of the things that we saw in the data that was really frustrating to us was, first off, because of the emphasis on the competition, you know, the schools that won, right, the schools that did well, tended to be the kids who didn't need the intervention in the first place, right? So it was kind of like, we'll get this out kind of middle of the road, you know, somewhere between that and the cross-country team. And if there was a school-wrapped program around it, then they tended to participate well. We expected, because we were naive and optimistic, but we wanted to see data on the weekends, so we could tell when the kids, you know, we had the daily data, right? So we could see the steps during the school days, and like, okay, the kids are mostly sedentary, they're sitting in school, and then we could see the steps on the weekends, and we hoped that this competition would inspire them to be more active on the weekends. Really disappointed to see that actually the weekend numbers were far worse, right? So we had anecdotal data of, you know, the kid that would go walk the dog with their parents and to get steps, but that was pretty rare in terms of the data set we saw. So that was, and it was also really interesting set of school systems. So that was an interesting set of research that identified challenges for us that then we took into an NSF grant to say, okay, if we were going to design this experience kind of from the get-go, so let's start with the premise. Again, we're handing out pedometers to kids to try to increase physical activity. How would we design interventions around that to get the results that we wanted? So we focused on, for example, screening and looking at how the kids saw themselves as being healthy or physically active. So if they weren't athletes, which were the populations that we looked, how much they actually identified with health and physical activity as being part of who they were as adolescents. We focused on trying to create some gaming mechanisms, so lots of dying on the sword, trying to create effective game design, but trying to create some gaming mechanisms that would encourage that. But gaming's tricky because the whole point is that we want them outside walking, right? We don't want them sitting there playing computer games. So the question was how to design very short bursts of interaction that was based on encouraging physical activity. So you essentially, you earn points by your steps, and you can spend the points in the game to do cool things. Kind of sort of worked, but we got there. And then I think more importantly is that we went to a non-competitive model. So in this case, we were being informed by observational learning and social cognitive theory, in the sense that if we wanted to reach that bottom tier of kids, then creating a little leaderboard where like the best people were winning and everybody else was falling behind was going to de-incentivize our folks. But if we created an experience where you knew where you were, but everyone else didn't, then you could see like what you had to do to like not be in the bottom of the pack. And more importantly, we created a, I guess our first chatbot. We created a social system where the system would go like, yay, James, like you got your steps today. And then other people would pile on who were kind of the real world social actors in the program. And then, so our system was trying to insert messages kind of just enough to keep that social interaction going. And so what we saw in that was that our research did seem to be more effective. This approach of kind of the observational learning and non-competitive approach did have the effect we wanted. All right, so we were excited about that result. The game design was kind of a failure, but no surprise, designing games is hard. And this relationship between online and offline activity was difficult. But what we also saw was, again, the school is the social context, right? So we weren't designing just for a kid or just for a group of friends, that we were designing for that social construct, right? Just like we had our relationship between our diabetics and their educator, just like we had the relationship between family members, that those were such powerful social forces. And in the last comparison study we did, really the only factor that mattered was the strength of the ties amongst the kids, and the decent tie strength. They weren't strong ties, but decent tie strength really made a difference, as opposed to kids that were all kind of there in the room at the same time, but they really had no other relationships with each other. So, you know, part of what we learned about this was that it's really, really hard to move the needle in terms of changing this kind of behavior, but a number of interventions, you know, focused around certain levels of social comparison, non-competitive behavior, as well as trying to shift their perceptions. So the other things that we were able to see in the data was if you were starting to shift their perceptions about, I may not be an athlete or a jock, but I can be kind of a physically active person, that if we could increase that, we also had a stronger effect. So, and that was Andrew Miller's work, who's now a professor at Indiana. So I've now wrapped up kind of the completed dissertations within this, and I want to shift a little bit to some of the work that we're doing now, and then be thrilled to take some questions before we're out of time. So, from a perspective of aging or diabetes or the changes associated with adolescence, and going all the way back to my everyday computing, ubiquitous computing hat, one of the things that we were frustrated with was that you know, this was something where time, the temporal journey made a big difference, right? These were not just, you know, snapshots or moments in time, but we were looking at, you know, aging over time and social relationships. We were looking at how people were learning to become more effective with diabetes, but that also played out over time. And when we worked with adult diabetics, we saw kind of a whole nother set of chapters to their journeys. Adolescence, by definition, is a journey. And so we wanted to create technologies that recognize that temporal nature of healthcare. And the language that we've started to use is kind of designing for the journey. And there's a number of ways that we've looked at this. I think my animation will work. So as a human-centered computing person, when the industry, healthcare industry, started using the term patient-centered care, how many people have heard of that term? Yeah, okay, you guys should have. So I got really excited. I'm like, patient-centered care, that's what we would do. It would kind of focus on the needs of the patient, and it would be kind of really focused on that, you know, that holistic experience around them. And then I realized that patient-centered care was actually the coordination of care by the doctors who were kind of surrounding the patient. And you know, psychologically, it kind of feels like this in my mind, right? You know, that poor woman who's just, you know, kind of surrounded by healthcare. And yes, it's good that we have collaborative work and coordinated care, but it wasn't kind of what I was about or thinking about. Because when I was talking to folks, patient-centered care was more like this. And we've been working with cancer patients, and you know, they describe, what they describe as cancer is an unwelcome visitor into their otherwise complicated lives, right? And patient-centered care is about healthcare, but it's also about jobs and children and family and chores and things that you have to do. And I've been working with breast cancer patients, so I've got women in the sandwich generation of still taking care of older parents and spouses and children. So they've got a lot going on. And so for them, supporting the healthcare journey meant integrating healthcare support into that complicated daily life. It didn't mean just like orchestrating their care. And so the things that we have started to work on is this notion of, well, how would we provide kind of day-to-day support that would have this holistic perspective to it, and how would we kind of tailor that support based on the work that they were doing, their healthcare experience. So this is a picture of our first tablet computer. How many people are diamond age? How many people are in the diamond age? You guys got to read your science fiction. It's part of your curriculum. We need to change that. All right, go Google that later. There's the young lady's primer, right? And it's about education, but it's this personalized tablet computer that is delivering kind of just what the person needs to learn at this particular time. So we kind of took that metaphor and said, okay, if we could hand a device to an individual connected to their healthcare system, how could we provide that same level of day-to-day support? So our first one that we valued was this little pink tablet. And so we learned a number of things from that experience. So the way the tablet computer worked is that we had a set of vetted healthcare resources on it. It literally was practically a PDF version of all the pieces of paper they would used to give folks. So if you were a cancer patient and you were checked in and diagnosed, they would here's everything you need to know. And it would be this big binder. That binder matters. We'll come back to that. And so it was a set of vetted resources and connections to their cancer navigators and their healthcare providers. But it was an open platform. So I want to tell you kind of some ahas within this work. So one of the first ahas was that, remember my desire to always find a good informant? So in this case, my good informant are folks called cancer navigators. So I don't know anybody here who's worked with a cancer navigator, knows of them, has had a family experience with cancer navigators. They tend to, in the US, they tend to sit just outside of the healthcare system. So they're not nurses or clinicians, but they are there to help remove barriers to care. And they were first invented actually coming out of Harlem, looking at trying to decrease or increase screening, so decrease barriers to screening, and they have evolved since then. And the idea is that they personally are trying to provide that holistic model. So, for example, if you're worried about insurance, which is a thing in our country, if you are worried about gas money or transportation to get to care, if you're really anxious about your diagnosis and treatment, they're working to provide that holistic model, but they're very few and far between. So this is where we talk about kind of the scaling and amplifying care. So we partnered with these cancer navigators and started to say, okay, how can we take what you know to do really well, but there's only 2.5 of you for hundreds of patients, and how can we amplify that? So we came up with this tablet computer. Remember I said it was an open platform, all right? This was actually a big deal because doctors don't like things that are open. And the way that some of our clinicians thought of this is they really thought of it as a treatment. And what do you do with treatment? You nail it down, right? So it was discussions like, well, we don't want the patients going on the internet. They're doing that anyway. We want the tablet to only be what we have prescribed to be on the tablet. And the fact that tablet sounds like a pill kind of reinforces this notion. So we somehow won that initial argument to say, let's just leave it open and see what they do. So one of the things that we saw in terms of what they do was they downloaded stuff. They downloaded games, they downloaded Bibles, they downloaded movies and books. And when we would interview folks and we watched the activities of how they use the tablet, from their perspective, well, this was fair. This was a healthcare resource too. So we actually had a working paper title called Angry Birds During Chemo, which is actually like a perfect use of Angry Birds. So the idea from them is that they were looking at their cancer journey more holistically, and if it meant new recipes or books to read or games to play, then that was, from their perspective, fair game as a healthcare resource, even though our physicians never would have approved Angry Birds as part of our intervention. The other thing that was surprising for us was they described that they liked the tablets because it was more private. It afforded privacy. And this didn't make sense to us until they sat down and explained it to us, which was I'm working in Rome, Georgia. It's a little rural town, even smaller than Ann Arbor. I come from Atlanta. So it's, everybody knows everybody. And especially for these women that are getting all these complex social relationships, if they're sitting in the waiting room of a hospital with that big binder on their lap, everyone who walks through that hospital waiting room knows they're a cancer patient. However, if they're sitting in that waiting room with a really cool slick tablet in their hands, they could be waiting for a friend, they could be a lot of their, it's plausible deniability in terms of where they are in that healthcare system. So they love the mobility, they love the privacy, they love the control. They describe the paper binders as kind of overwhelming, but they could they could dip into the tablet and then put it away. Or more importantly, is they could use the tablet for other reasons, which meant they kept it charged and kept it part of their ongoing lives. So we had, a level of success in the sense that people used this tablet. It was just a probe. We were just getting it out there. Technology literacy wasn't a barrier. Surprising, we established that in the work we were doing. And so we took that initial data, and now we're designing a system that now looks at this notion of customized and adaptive support. And what I mean by that is that the information on the tablet now is personalized for their diagnosis, for their treatment plan, for their schedule. And so every day when they interact with that tablet computer, you're about to have surgery, you're starting chemo, you're in day 3 of chemo. This is where you are, and these are the resources that you would need. So that's where we're trying to get closer to that science fiction concept that nobody in this room knows, but that young lady's primer, right? And I could wave my hands and say it's AI. There's so much low-hanging fruit here. It's just simple rules, right? It's not that complicated, but just doing that. And then the adaptive part is then we have surveys, again, not terribly complicated. It's just there, and they can answer it when they want to. But it's a combination of material from the National Cancer Distress Scale, so validated survey instruments, as well as our own questions coming from the socioeconomic barriers that we can use to probe and be more adaptive. So if there's a lot of concern about side effects, we can register those concerns, and then if our system is smart enough, which it isn't yet, or the healthcare navigator is smart enough, then we can assure the person, actually these, chemo day 3 really, really sucks. It's gonna be okay. Don't go to the emergency room because, by the way, you're immunocompromised. And the last thing we want is you picking something up because you're in the emergency room. That's actually a real challenge with these systems. Or it can be, again, I'm worried about childcare and transportation. We know that surgery is coming up in 2 days. We can flag something now on the dashboard for the navigators to say, this is a patient you really want to reach out to because missing one chemo appointment can be deadly in terms of the outcomes that we're looking at. So it's, again, not AI complex, but it's just enough kind of adaptive support to see how this works. So we're piloting this now, and then we'll be going, not quite RCT, NIH level, but doing a major trial of this starting in January. And this is Maya Jacobs' work. So 2 last projects that are even more formative, but are starting to percolate in our laboratory. So we are doing a little bit more in kind of the wearable sensing side, but in this case we're now working with adolescent epileptics. Self-report of seizures is incredibly important to getting medication and treatment correct. However, reporting seizures is really hard, just period, because some seizures are essentially quiet seizures. You don't even know you had them. You have seizures in your sleep. You don't know you had them. And adolescents aren't good at reporting anything anyway. So we have a lot of barriers to kind of getting that information. So what we've been doing is working now pretty directly with clinicians just to understand, okay, what kind of seizure detection can we reliably get from wristbands? What kind of improved reporting outcome can we get if it's combined with other sources of information? So in this case, in the EMU studies that are in a hospital setting, video is appropriate. Actually, for a lot of young kids with seizures, video is appropriate because the parents are using the cameras anyway because they just need to be able to look in and see that their kid is okay at night. So you can do a video review with automatic detection and get pretty good accuracy. And then once we have those pieces in place, how do we also have mobile and wearable tech to try to get other symptoms and other points of self-report working? And in this case, we're looking at kind of classic CSCW incentive design? Does perception and knowledge of an audience matter? Do rewards work for the kids? If we do context-aware reminders where we know that the parent and kid are together because we know that they're both at home because we can see where their cell phones are, does timing a reminder at that point in time work? So we're taking a lot of kind of classic lessons from the literature and then seeing if it works within this adolescent context. Really, really challenging population to work with, but it is one area that we can have pretty significant impacts. Kind of the learning and cognitive challenges that these kids are facing because of what the epilepsy is doing to them and what being on the wrong medications is doing to them makes a big difference. So if we can make any progress there, we will move a needle from a clinical outcome perspective. And then last, that will work, okay. Apologies, I actually tried to get the tamest imagery here. I want to return back to my UBComp roots and talk about a project that has been kind of a bit of a game changer for me. So remember those kids who were doing the camps and the pedometers and the schools and all that? So when we were working with those kids, we started to look at just kind of their use of mobile and media technologies in general. We also had a little cyber safety program running on the side. So we were just trying to understand what they were doing and why. And especially when we were working with adolescent girls, bullying would come up. We got a little bit of that, but we were starting to get hints of interactions online associated with eating disorders. And this was kind of a surprise for us. You know, we just really wasn't on our radar. And that kids were essentially going online and finding sites or material that was facilitating, encouraging eating disorders. And so when we saw this, we started to we were concerned and surprised by this idea, but in particular from a UBComp perspective, one of the things that really worried us was that in my entire career, remember all the way back, pervasive access to computing is a good thing, right? Having computing around you all of the time, having ease of access, having anonymous access, we're all kind of mostly positive values in our field. And what we were starting to see in the work around these communities was that it was actually very damaging from a health perspective. And the kinds of content that we've been looking at have been essentially online communities, so take all of our online communities knowledges that inspire and share best practices for unhealthy eating disorder behaviors and other forms of self-harm such as cutting. So we've been trying to kind of get a handle on what this looks like. We've had a past CSCW paper, we're going to have another CSCW paper early next year, as to what does this look like and what is the impact of it. So some of the things that we've looked at in terms of what does it look like is we've done media content analysis around what kind of content is out there and what does it matter and why. So there are genres of content that are essentially called thinspiration that are motivating a pro-anorexic lifestyle. And so this is, again, kind of, just as I would have a diabetes website, which is how to be healthy and how to have best practices, these are websites that are exactly the same, but it's like be the best anorexic you can be. There are cutting sites that develop material that are actually designed to trigger or incite cutting behaviors. And so our next step in this work is then to say, okay, does this content matter and is there a clinical connection? So we're now forging collaborations that help us understand that different facets of eating disorders may be associated with different types of experiences online. And it may prove to be, again, facilitating or encouraging or leading people into those types of behaviors. And then the last question is, okay, if there is this interrelationship, which we really believe there is, then how could, what would intervention start to look like? And it's a challenging space for us because, again, go back to that pervasiveness. So the analogy that we use is, it's the 1950s and you're trying to stop smoking, right? But everybody around you smokes. People smoke at work, people smoke at home, it's pervasive. Like, how do you get away from that? So if you're constantly online in these types of spaces, how do you disconnect from that? What does it mean to actually negotiate a more healthy relationship with online interaction. And it's a complicated space. So one of the things that we've seen in the media analysis that we've done, and I'll stop with this, is that you know, the platforms, Instagram and folks, are trying to essentially squash or censor this type of content. So the communities are very facile with hiding and negotiating and staying linked to each other. So there's all sorts of crazy tagging going on in terms of how folks are able to share content in a way that they won't get caught by the censors. So, you know, the platforms are motivated in terms of how to reach out and help individuals that are engaged in these kinds of behaviors, but they need kind of the tools and the techniques for how to design for this going forward. So for the first time in my research career, it is the relationship of there is a healthcare challenge out there. Eating disorders and self-harm have been around for a long time, but the ubiquitousness of this has actually made it far worse. And anorexia as a whole is 12 times, see if I can get this right, for 12 times more lethal in terms of mortality for adolescent girls than all other things combined. Right, so it's actually non-trivial in terms of its impact on public health, but it's an area that's receiving very little treatment, very little attention. So it's a new space for us, but it's, you know, again, if you think of kind of the themes and the things that we've looked at over time, you know, problem solving, detective, engagement, comparison, what is normal, what is identity, right? All of these forces are coming into play in these types of environments. So this is, again, the space that I've been working in. So 1 decade in 50 minutes and 6 dissertations. So either done or in progress. And this is really what I wanted to share. So thank you for your time.
We'll have time for 1 or 2 quick questions. Yes.
First, thank you that was a very enjoyable talk. My question is, you know, we're familiar with the goals of consumer health, empowerment for the patient, sense of control, but how often do you actually see that it's patient-driven or is it more healthcare provider-driven that wants to accomplish it? And my second question would be, is there a true impact? Do you see behavioral modification with this personal health technology?
Yeah, and these things are interrelated, right? So I've worked with a lot of collaborators that are like, just tell the patients what to do, right? If they just did what they were told, we'd all be fine, right? Can I design a technology that would do that? And we should know by now that doesn't work, right? And the patients aren't going to do it anymore just because they got it in a mobile phone versus a face-to-face conversation. So in this case, where I am seeing the impact goes back to my original statement, which is health is negotiated, right? My diabetics were not striving to be the best diabetic possible. You know, they were not carrying around bags of broccoli to nibble on. But they wanted to be healthy enough for the goals that mattered to them. And I think a real challenge for our field going forward, and this is actually going to be kind of the next version of the cancer work that I'm doing, especially looking at survivorship, is that right now it's personalized around treatment and barriers. I want to personalize it around goals, right? I want to personalize it around these are the things that matter to me, and this is the coaching or the help that will help you get there. Okay, physicians don't like that, right? Because they're mostly still in the just tell the patient what to do. But if you look at whether it's aging or diabetes or I think some of the mental health issues that we'll get into, it is a, I want to set my goal, this is where I am, this is where I am within my social circle and work there. And if I focus on that middle road and I focus on nudges and ways of helping people to get there, then yes, I see changes in behavior. But I don't take a cheeseburger and fries person and turn them into, the salad bar person, right? It's just, they may decide to do that on their own, but there is not a proven intervention that is going to do that. So understanding that it's social, that it's negotiated, that is every day, and if we could frame it around that, I think we could actually make much more progress than we've made this far. Way in the back.
Thank you so much for your excellent talk. 2 practical questions. One is like a lot of your projects, especially like the cancer project, has to do a lot with the EHR, patients and stuff. How do you handle tapping into each EHR and
Yeah.
Second is, how, for these amazing studies, how do you sustain them so that it becomes something that is really beneficial to society rather than not just a journal?
Yep. Two beautiful questions. You're really going to laugh at my answer on the cancer one. So we have a particular interoperability solution for the cancer tablet, and that is I have a person who has access to the EHR and types in the information here. I have human interoperability because the hope is that when we are able to show the benefits of the system, then finally the IT folks will be, okay, we'll bother to do it. But if I waited until interoperability happened, I would still be holding my breath. The first time we did the tablet design, we got as far as they printed a PDF and stuck it in a file that nobody looked at. Right, so I have to find that human part of the network, make the interoperability work, and then use that to drive the rest of this. And luckily, the folks at NCI understand that that is our approach. Sorry, what was I saying? Oh, sustainability. It's a real challenge. One of the things with my other hat as the director of the Institute for People and Technology is we have a whole applied research and economic development arm. So with both the epilepsy project and especially the cancer project, there are whole other teams that are now taking this from an economic development point of view and bringing this to cancer care systems. So they're actually a version behind us, but then their work is to find cancer systems that are essentially implementing this, and they can get funding from other places that look nothing like the funding I get to do this. So I think creating that network really matters with the cancer work, and I think some with the epilepsy work that we're doing because we're working with commercial partners. We are actually creating the legs to the project that will lead towards long-term impact. But it's a lot of work. It's really hard. The NIH project with diabetes, it's creating a curriculum on that website that is recent, it's current now. Will the other folks who own that curriculum continue engaging in that website? I don't know, it's a challenge.
We'll have to wrap up there, but let's thank Beth again for